She had been taking it every night for 8 months. Her doctor prescribed it. Her pharmacist filled it without comment. The label said anxiety. The pill was small, white, and unremarkable. Her name was Diane, 53 years old, high school principal, a woman whose entire professional life depended on her ability to remember names, track conversations, manage dozens of moving parts simultaneously, and do all of it under pressure. At month 7, her husband started noticing things. A meeting she had scheduled twice because she forgot scheduling it the first time. A word she couldn't find in the middle of a sentence. Not an unusual word, a common one. A name she reached for and came back empty. Small things, the kind of things you dismiss. At month 9, he stopped dismissing them. He found her standing in the kitchen at 11 o'clock at night, holding a glass of water, staring at the window. When he asked what she was doing, she said she didn't know. She had gotten up for something, and now she couldn't remember what. Her doctor ordered a brain scan. The results showed measurable atrophy. Not the atrophy of a woman in her 70s or 80s. The atrophy of a woman in her 50s who had been taking a medication that does something to the brain that most people who take it every night have no idea it does. The medication was not experimental. It was not obscure. You have almost certainly seen it. You may have taken it. It is sitting in medicine cabinets across America right now. Sold over the counter. No prescription required. Less than $12 at any pharmacy. And a body of peer-reviewed research, including studies spanning hundreds of thousands of patients, links long-term use of this class of medication to measurable changes in brain structure, significant associations with cognitive impairment, and, in multiple large studies, an elevated risk of dementia. Stay with me. Because by the end of this episode, you will know exactly what it is, what the research actually says about it. Not the alarming version, not the dismissive version, but what the peer-reviewed literature actually concludes, and what to take instead if you need what it's being taken for. This is Case Zero. The medication Diane was taking belongs to a class of drugs called anticholinergics. It is a word most patients have never heard. Their doctors use it. Their pharmacists know it. The people swallowing these pills every night, tens of millions of them, usually don't. Anticholinergic. Anti, against. Cholinergic, relating to acetylcholine. Acetylcholine is a neurotransmitter, a chemical messenger. Think of it as one of the brain's primary communication signals, the one that governs memory formation, focused attention, and the ability to learn new information. When acetylcholine binds to its receptors in the brain, it facilitates communication between neurons. It is essential for the kind of thinking that lets you recall a face, follow a complex conversation, or retrieve a word you know perfectly well you know. Anticholinergic drugs work by blocking that signal. That is not a side effect. That is the mechanism. That is how they achieve what they are prescribed to achieve. For overactive bladder, they block the nerve signals that cause urgency. For motion sickness, they suppress the signals that trigger nausea. For sleep, and this is where it gets important, they block the signal that keeps you alert, which is why they make you drowsy. In the short term, for the right patient, for the right duration, this blocking effect is therapeutic. It does something useful. The question that has generated an enormous body of research over the past 15 years, is what happens when you block that signal night after night, month after month, in a brain that depends on it. Here is what the research actually says. And I want to be careful with this because the science is honest about what it knows and what it doesn't. The first landmark study came out in 2015, published in JAMA Internal Medicine by Gray and colleagues. They followed 3,434 older adults over 10 years. What they found was a significant association between higher cumulative anticholinergic use and an increased risk of developing dementia. The hazard ratio in the highest cumulative users was 1.54, meaning roughly a 54% higher risk compared to non-users. That study was followed in 2016 by by research published in JAMA Neurology, the study that produced the finding that ended up in Diane's scan results. Researchers compared 391 older adults who were not taking anticholinergic medications with 60 older adults who were taking at least one medication with medium or strong anticholinergic effects. They used neuroimaging. What they found was measurable brain atrophy, reduced brain volume, in the group taking these medications, along with reduced brain metabolism in regions associated with memory and cognition. Not a subjective decline. A structural, measurable, visible difference. On a scan. Then, in 2018, a study published in the BMJ examined approximately 325,000 people 65 years and older. It found again a significant association between anticholinergic medication use and dementia risk. And then a systematic review and meta-analysis, pooling the data from multiple studies, concluded that taking anticholinergics for 3 months or more was associated with an average 46% increase in dementia risk compared to non-use. Now, I want to be direct about something because the science deserves honesty. These are largely observational studies. They show association, not proven causation. Some researchers point out that people who need these medications may already have underlying conditions that increase cognitive risk, and that the medications may be a marker of that risk rather than a cause of it. A 2023 study published in Alzheimer's Disease and Associated Disorders did not find a conclusive link between anticholinergics and dementia, but did find a significant association with mild cognitive impairment, which itself carries a 10 to 15% annual conversion rate to dementia. So the scientific picture is this: not certainty, not proof that a single pill causes Alzheimer's, but a consistent, replicated signal across multiple large studies, across different populations, across different research designs that points in the same direction, and a plausible, understood biological mechanism that explains why. That mechanism is worth understanding, because once you understand what these drugs are doing inside the brain, you will not look at them the same way. Your brain maintains a very specific chemical balance. Acetylcholine is one of the key molecules in that balance, particularly in 2 regions that matter most for memory: the hippocampus and the cerebral cortex. When you take an anticholinergic drug, it crosses the blood-brain barrier, the protective filter between your bloodstream and your brain, and it occupies the receptors that acetylcholine is supposed to bind to. With those receptors blocked, the signal cannot get through. Neurons in the hippocampus and cortex cannot communicate the way they normally do. In the short term, this produces the effects you might recognize: grogginess, mild confusion, that foggy, slightly not quite present feeling the morning after a sleep aid. Those effects are the short-term consequence. They are uncomfortable, but they resolve. What the long-term neuroimaging research suggests is something more concerning: that sustained blocking of these receptors, month after month, may not be fully reversible. That the brain, deprived of normal acetylcholine signaling over extended periods, may begin to change structurally in ways that do not simply disappear when the medication is stopped. And here is the detail that makes this especially significant. As we age, our natural levels of acetylcholine already decline. It is part of normal brain aging. The same neurons that produce acetylcholine in younger brains become less efficient over time, which is part of why memory and learning naturally shift with age. An anticholinergic drug taken by a 35-year-old with abundant acetylcholine activity is a different biological event than the same drug taken nightly by a 65-year-old whose acetylcholine system is already running at reduced capacity. You are not blocking a system at full power. You are blocking a system that is already compensating. That is the compounding that the research keeps returning to. And that is why the American Geriatric Society, in their updated 2023 Beers criteria, the clinical guidelines for potentially inappropriate medications in older adults, specifically lists strong anticholinergics as medications to avoid in patients over 65 wherever safer alternatives exist. Now, what medications are we actually talking about? Because this is the part that surprises almost everyone. These are not medications that feel dangerous. They feel ordinary. They are ordinary. The one most commonly encountered is diphenhydramine. Most people know it by its brand name, Benadryl. Diphenhydramine is a first-generation antihistamine, the active ingredient in Benadryl, but also in Tylenol PM, in Unisom sleep tabs, in Zizquil, in Simply Sleep Equate nighttime sleep aid, and a long list of store-brand equivalents, all of them the same molecule. Tens of millions of Americans take diphenhydramine for sleep. Many of them take it every night. Many of them have been taking it every night for months or years. Most of them do not know that it is an anticholinergic. Most of them have never been told. But diphenhydramine is not the only one. Hydroxyzine, sold under the brand names Vistaril and Atarax, is a prescription anticholinergic prescribed for anxiety. It is the medication Diane was taking. Oxybutynin and tolterodine, brand names Ditropan and Detrol, are anticholinergic medications prescribed for overactive bladder. They are among the most commonly prescribed drugs in adults over 65. Scopolamine, the patch used for motion sickness. Meclizine, used for vertigo. Many tricyclic antidepressants. Certain antipsychotics. Certain antiemetics. The class is wide. The medications are common, and the people most likely to be taking multiple anticholinergics simultaneously, which compounds the burden significantly, are older adults managing multiple conditions. A person taking hydroxyzine for anxiety plus oxybutynin for bladder control plus diphenhydramine for sleep is taking 3 anticholinergics simultaneously, each one blocking acetylcholine, the effects stacking. This is what clinicians call anticholinergic burden, the cumulative load of acetylcholine blockade across all medications a person is taking at once. And it is remarkably common in older adults and remarkably under-recognized. Back to Diane. When her neurologist reviewed her medication history alongside her scan results, the hydroxyzine she had been taking every night for 8 months became the central question. She was not 75. She was 53. She had no family history of dementia. She had no other identifiable risk factors. The hydroxyzine was stopped. Gradually, carefully, with her physician's guidance, not abruptly, because stopping certain medications suddenly carries its own risks. Over the following weeks, some of the fog lifted. The word-finding improved. The disorientation at night stopped. Her follow-up scan, conducted 14 months later, showed partial improvement in the areas of concern. Partial, not complete. That word matters. Because the research on whether the brain changes associated with long-term anticholinergic use are fully reversible is not settled. Some studies suggest recovery. Others suggest that prolonged exposure may leave structural changes that persist even after the medication is stopped, which is why the clinical guidance is not, stop these medications if you are over 65. The guidance is, use the lowest effective dose for the shortest effective duration. Evaluate regularly whether continued use is necessary. And where safer alternatives exist, prefer them. That is different from panic. That is appropriate caution. And it is a conversation most patients are not having with their doctors, not because their doctors don't know, but because no one is asking. Here is what to do with this information. Specifically, today. Step 1. Identify whether you or someone you care for is taking an anticholinergic medication. The most common ones to check for: diphenhydramine, in Benadryl, Tylenol PM, Unisom sleep tabs, Zizquil, and most store-brand nighttime sleep aids. Read the active ingredient label. If it says diphenhydramine, it is an anticholinergic. Hydroxyzine, Vistaril or Atarax, for anxiety or sleep. Oxybutynin, Ditropan, or tolterodine, Detrol, for overactive bladder. Meclizine, Antivert, for vertigo or motion sickness. Certain tricyclic antidepressants including amitriptyline, doxepin, and imipramine. If you are unsure whether a medication you are taking has anticholinergic effects, the Anticholinergic Cognitive Burden Scale is a publicly available reference that rates medications by their anticholinergic strength. Your pharmacist can run through your full medication list against it in a single appointment. Step 2. If you are taking one of these medications regularly, particularly if you are over 60 or if you have been taking it for more than 3 months, bring this specifically to your physician, not as an alarm, as a question. The question is, given what the research shows about anticholinergic burden and cognitive risk, is there a safer alternative for what I'm using this for? Because for most conditions these medications treat, there are alternatives with minimal or no anticholinergic effect. For sleep, melatonin, low-dose doxepin in specific cases, cognitive behavioral therapy for insomnia, magnesium glycinate. Your physician can guide you on which is appropriate. For allergies, second-generation antihistamines, cetirizine, fexofenadine, loratadine. These are Zyrtec, Allegra, Claritin. They treat the same symptoms. They do not cross the blood-brain barrier the same way. Their anticholinergic burden is dramatically lower. For overactive bladder, mirabegron, brand name Myrbetriq, is a non-anticholinergic alternative that your physician may be able to prescribe. For anxiety, the conversation about alternatives is longer and more individual, but it is a conversation worth having, particularly if you are using an anticholinergic like hydroxyzine for long-term management rather than short-term relief. Step 3. Do not stop any medication without talking to your physician first. This is not optional. Some of these medications have withdrawal effects. Some of the conditions they treat, overactive bladder, severe anxiety, certain types of nausea, can become significantly worse if medication is stopped abruptly. The goal is not to stop. The goal is to have an informed, specific conversation about whether what you are taking is the most appropriate option given what the research now shows. That conversation is yours to initiate. Most physicians will welcome it. But most physicians are not proactively reviewing every patient's anticholinergic burden at every appointment. The system is not designed for that kind of preventative scrutiny. You are. 1 night of Benadryl. 2 nights. A week when the allergies are bad or the sleep won't come. That is almost certainly not what the research is pointing to. The signal in the data is about sustained, cumulative use. Months. Years. High-burden combinations taken simultaneously. That is the pattern that shows up in the studies. That is where the risk appears to concentrate. But tens of millions of Americans are not taking these medications occasionally. They are taking them every night. Because sleep is hard. Because anxiety is real. Because overactive bladder is uncomfortable and disruptive and embarrassing to talk about. Because a drug that works in the short term becomes a habit, and habits become years, and years become a cumulative burden that no one calculated because no one knew to. Diane didn't know. Her doctor knew the medication worked for anxiety. He did not spend the appointment reviewing her cumulative anticholinergic exposure. There wasn't time, but you have time, right now, to check the label, to make the call, to ask the question, because the difference between long-term anticholinergic exposure and choosing an alternative is not a dramatic sacrifice. It is not a major lifestyle change. It is a conversation with a pharmacist, a different product from the same aisle. And for the brain, particularly the aging brain, it may matter more than almost any other small decision you make. Share this with someone tonight, particularly someone who takes a sleep aid every night without thinking about what is in it, particularly someone whose parent is on multiple medications and has never had a pharmacist review the anticholinergic burden of the combination. The information is not frightening if you know what to do with it. Now you do. Next week on Case Zero, every 40 seconds, somewhere on this planet, someone has a stroke. Most of them had a warning sign in the 72 hours before it happened. Most of them ignored it, not because they were careless, but because the warning signs of a stroke in the hours before it becomes a stroke do not look like a stroke. They look like something else, something minor, something easy to explain away. We are going to walk through exactly what those signs look like and what to do in the 72 hours when intervention is still possible. That is next week on Case Zero. Do not miss it.